all of our physicians and all of our colleagues who join us online. Good evening, everyone. And I am Liang Jiarui. I am Director of Infection Control Center for Eastern Memorial Hospital, Associated Professor, National Yangming Chiao-Tun University. Today, I'm going to share with you clinical considerations when choosing for the next treatment. This is my financial disclosures. And actually, we can see from this HIV drug development line, we can see that in 1981 that we have get it for this first descriptions regarding to the AIDS. And then afterwards, in 1987, we have for this zidovudine, which has been approved by the FDA. And then afterwards, we can see that for the continuities of the development for the HIV medications, and also later lines, we can see there is a much evidence showed which for this combination therapy will have better for the efficacies and also to have a very good for the control for the HIVs from and for long times. And also we have a great development afterwards. After for this treatment initiations, and then after for the patient to have a maintaining for a stable, and then they will also think about whether we should switch for different ARTs. And just for example, in Taiwan, we can see for the HIV care continues. And we can see that for the people living with HIV, and we can see that 90% of them are receiving for the ART therapy. And also among those, 95% them has already just achieved for this viral suppressed states, which means that we cannot detect any of this viral load. And then we can see that with a adequate control actually for just for their manifestations and also for the symptoms have been well controlled and managed. You can see life expectancies of people with or without HIV. This is a comparison conducted in the US. They are using a big scale of databases. And then for the cohort of adults with HIV in care 2000 to 2016, and then they are matched with 1 to 10 with people without HIV. We can see that in the study population, average age is around 40, and they actually using for the statistics capabilities to see if the patient has been diagnosed at age 21, and then from different year, and then for their life expectancies is very different. And then there is a 40 years of the extensions at that time. So which means that if that is 2000, if the patient was diagnosed as age 21, and maximally they will have around 40 years of left life, which means that the patient will live until their 60s. But however, if the patient diagnosed at age 21, in just for example in 2014, and then they will have another 50 years of the life expectancies. So this is very different. And then we can see different marks in here. And we can see that if for the HIV infected patient, and when they are just appearing with other comorbidities like diabetes, hypertension, and also cardiovascular disease, if compared with the patient without any of these comorbidities, and they also have a very big difference for the average life expectancies. So that we could consider for those individuals with the extending for the life expectancy for those individuals, we also need to help them to avoid or prevent for those chronic disease or comorbidities. And if they already have the chronic disease, how could we prevent for the onset of the diseases? And why do we consider a next treatment regimen? And we need to think about when should we moving forward to the next stage. And when we are changing for the formulas or changing for the prescriptions, there are a lot of different reasons. Just for example, when we are having for this viral failure or treatment failure, and then we probably wanted to just simplified for the regimen or like losing for the patient's dosing frequencies, etc. And also in Taiwan, like a majority of the patient, they are following this kind of like strategies. And the other driving force for switching for the ART is to enhance tolerabilities and decrease the short or long-term toxicities. So this is one of our focus now. Besides these just like factors, also including like to prevent or like mitigate for the drug-drug interactions, or probably the patient they have to take the medication with food, and then some patient they could not cope with that, so they have to switch. And the other part of the reason is to reduce the cost that is just like induced by this ART. And by the other words, we can see that now we are more transforming into a person-centered approach for the care of people living with HIV, so that in the regular communication with our patient with the HIV just infected population, we're giving them suggestions, and maybe that they have appeared some symptoms with the drug-drug interactions, maybe for their special conditions like pregnancies and special medical histories, etc. We're providing them with coding suggestions. And also, we need to pay attention to the HIV infection, which will cause for the other health related issue. Just for example, for the drug itself will cause for some long-term impact to the patient. These are some of the symptoms that is undesired by the patient. Just for example, for the aging and fatigue, and this will also be mentioned afterwards. And probably for the mental health, for like neural health, for the cardiovascular diseases, cancer, chronic kidney diseases, bone diseases, osteoporosis, or like endocrine health, etc. In the early prescriptions, actually, we can see from some like Japanese studies, for some medications itself, it will have the impact or have the correlations with like for this like kidney or like a renal dysfunction. So that this study has showed for the TDF, for this medication through the time of the treatment, they will have the impact regarding to the renal dysfunction. With the 288 weeks, we can see that for the EGFR will have a 25% reduction. This is also closely related to the body weight. The heavier the patient is, the less they will see for this trend of the reduction. The smaller BW patients are much easier to have the TDF renal toxicity. Can see that in China and in Japan, as well as in like Korea, in this kind of like Asian countries, actually for the body shape or body weight of the patient is quite different from European or US countries. And we can see this is another Japanese and we can see for the result regarding to this study, we can see that for the cumulative exposure of the TDF associated with kidney, like tubulopathy, whether it is currently used or discontinued, we can see that for the patient, if they have received TDF more than 2 years, and we can detect for some of this like kidney, like tubulopathy, and other kidney-related diseases. All of these symptoms are like not reversible. So once it has onset, it cannot be like reversed. Besides for the renal dysfunction or a renal impact, in the previous a lot of studies, we also can see for the ABC or TDF, we have a lot of like large scale studies can see for associations with the CVD. And then we can see for these correlations. And also we can see it is around 1.5 folds and other kind of levels regarding to this like a risk increasing. And also we have a different for this like evaluations and also, like, besides for the ABACA, and we can also see for these associations between the risk of MI with ABACA, and we can see like for like Dolutegravir And for the IDV, we can see for the correlations with the CVD diseases, even though for the cause and for the causalities and for the consequences has not been seen like very directively. But however, with the very close monitor, we can see that when the patient have some cardiovascular disease risk, and then we need to have a early intervention to have a early like a switch for the for those ART therapies, and in order to prevent for the progressions of the CVD. And also we have some general principles of the for the ART switching. The first one is to maintain for the viral suppression, and no matter like under what kind of like circumstances we are doing for the ART switching, we have to follow for do not harm or don't mess up this kind of for this kind of like principles. And also we need to know some of these informations beforehand. Just for example, for the patient's previous ART history, maybe the patient they had some treatment failure, or they having for some resistant to certain medication. So before we are switching for the ART therapy, we have to know all of this information. We should just like avoid to like repeat to those like a failure treatment regimen. And also we need to see for the previously if the patient have demonstrated or possibly probably ARV resistant based on the history. In some special regions or countries, they have the capacity, they have the capabilities to do this resistant test. And then it is better like they can have a continuous documentations to see whether the patient they have the ARV resistant, and then we can get for the informations from this like documentation. And also we need to see once the patient has developed for the drug resistance, we need to see whether it can be detected in those potential infected cells or like latently affected cells. And then also we need to see for the patient's like compliance. Just for example, the patient they already developed for some like a resistant for PI, and then when we are switching the same category medication, we have to pay attention to see for the adverse events.
Where at the same time, for the patient, for any of the potential doubt regarding the side effect of the potential new drug prescription, whether patient would like to try it or not, it is also necessary to assess whether there's any interaction between the drugs and drug. Well, finally, of course, we also hope the prescription we choose need to have some good clinical evidence to make us feel confident for this conversion or switch. There are also some other considerations. For example, if the switch is actually to stop TDF, even haven't been started of using the TDF-based prescription. So in other words, we don't have not much suppression for the hepatitis virus. Then you need to pay special attention to the serum test of the hepatitis virus of the patient and whether the patient has been vaccinated before. In particular, we should also be able to note if the patient has an HBC, that is the co-antibody of the hepatitis B alone, to be positive, then its surface antigen is negative. Its surface antigen is also negative. So this implies that the patient probably be a recessive state of the hepatitis virus infection. Once you start the prescriptions that does not contain TDF or TDF, then you have to ask the patient to check its hepatitis virus frequently. And the second consideration we need to make is that right after the switch, it's better to re-evaluate the patient performance after receiving the new prescriptions, for example, after 4 weeks. We'd like to assess whether the patient has a good tolerability over the drug and whether there's any side effects happen. There's something quite special that we need to consider and also could be done by some hospital. And right before the switch, we can send the patient to go for the gene testing. If the patient has no way to know whether they are going to fail certain treatment, viral DNA probably be of their for great reference value. such tests will not suggest everyone to go for it. It's only for some specific situation. Then we would like to suggest the patient to go for the peripheral DNA test. Well, besides that, just like playing chess, we should also consider our next move. For example, if the patient failed the existing treatment, is there any other options being available in the near future? So before the switch, we need to have some options in our mind, making sure, and even if the patient failed the existing option, we'll still be able to provide a new options for patient to switch in the near future. We can say that regarding the possibilities of the switch, we need to have the clinical evidence to know if the patient using TDF-based treatment, it lead to abnormal kidney function, then patient probably switch to other treatment. The patient's kidney function will not be worse after or deteriorate after the switch. This is a clinical trial that has been done before. That is the TDF-based regimen. If the patient already have the chronic renal insufficiency, the primary drug to switch is the Jumboya, TAF, FTC, and cobicistate. So in such a follow-up process, even if it is a very small-scale study, but we find out for patients with renal insufficiency, and if they could be identified in the clinical setting as early as possible with the kidney functions, if it is necessary for them to go for switch, then TAF-based regimen would be one option they can consider. Besides the TAF-based regimen, be the mainstream switch, there are also some new antiviral options being available. There's a very special one that is the combined therapy of having two drugs. In other words, we remove one NRTI backbone and then to assist the patient for longer treatment in the near future. Well, if we're going to have the combined therapy with two drugs, we have to make some additional consideration. Some doctors, they may worry if the patient is able to tolerate the drug, does the patient need to have a very good compliance, or is it means that the treatment of the hepatitis virus could be impacted, whether reducing certain drugs going to lead to the compromise of the drug resistance threshold. But of course, in the existing evidence, we find out the difference of the medication compliance and the threshold of the drug resistance is no big difference compared with triple therapy. It also provides one additional benefit. Some patients would like to expect the drug residues and exposures to be reduced in their body. Reducing one drug for patients makes them feel much easier. While at the same time, they can also help to reduce the accumulated exposure of the drug-related impact. It can also help to reduce the drug-to-drug interactions. So for sure, nowadays, there are some of the drug combination that could be used by having two drugs in one. For example, DDG plus the RPV, and for example, 3TC plus FTC plus DTG, and the STR is actually the bottle. And we can also have the 3TC plus FTC plus DRV. It is also allowed. But more importantly, the fundamental principle is that right before the switch, the individual patient in the past 6 months, it actually needs to make sure its viral load is lower than 50 copies per ml. The patient has no history of resistance, and the patient HBV immunity with anti-hepatitis antibodies being identified. If the patient has no antibody, the patient has to be vaccinated to make sure the patient will not be compromised once an RTI is being withdrawn. So in the combined therapy, I think a great evidence being provided is the Tingle study. Tingle study is targeting some stable patients. They have been switched from a tough-based regimen to the water, or one cohort maintained with tough-based regimen, and the follow-up has been continued till 144 weeks. In such clinical trial, even if the patient only take two drugs for combination therapy, the control of the virus has not yet been compromised. So maintain the previous treatment or switch to the bottle shows the same result for viral suppression. That is also something I would like to see regarding the switch. Let me just make a brief summary. With the development and emergence of the new drugs, the treatment of the HIV become more stable. The average life expectancy has been getting longer, but there are also going to be some new problems show up. For example, the long-term toxicity of the antiviral drug, or if we're going to assist the patient to deal with some of the common chronic comorbidities as they aged. As we're choosing the new treatment, the most important thing is to maintain a very stable control of the virus. With this, we should also consider the patient's history of antiviral drugs. Does he or she has any chronic comorbidities, drug-to-drug interactions, and its zero marker of the hepatitis virus? That's all for my presentation. Thank you.